Hi, my name is Zoe, and my topic today is lower limb amputation, and I initially want to just describe what lower limb amputation is and its classification. So lower limb is any removal of the leg below the hip, and to initially start off at the hip is a hemipelvectomy, which is removal of the whole limb as well as half of the hip. And then there's hip disarticulation, which is removal of the leg at the hip. There's transfemoral, which is removal of the leg above the knee. Knee disarticulation is removal of the limb at the knee joint. Transtibial is removal below the knee. Ankle disarticulation is removal of the foot at the ankle. Symes is removal at the midfoot. And then there's digit amputation, which is removal of a toe or several toes. And then the prevalence of lower limb loss is 54% of it is vascular disease, 45% is due to trauma, leaving less than 2% due to cancer and congenital defects. So most amputees with vascular disease are over the age of 55 and they had complications with diabetes or atherosclerosis, and most amputees with limb loss due to trauma are under 50 years old. Any trauma can be caused from a motor vehicle accident, crush injuries, ischemia, chemical or electrical burns, and frostbite. And with amputations, there's a slight gender gap. So 41% of amputations are females and 59% are males. That leaves 2.1 million people with limb loss. And on average, 507 people have an amputation per day, meaning that roughly 185,000 people have an amputation annually. So to manage amputation, it can be managed with an exercise program, which is worked alongside a physical therapist and occupational therapist, use of walking aids, and a prosthetic if they're fit for a prosthetic. For medications, NSAIDs, antidepressants, opioids, and corticosteroids may be prescribed to alleviate stump and phantom limb pain. NSAIDs used for a brief period is beneficial for short-term recovery by helping manage inflammation. Some antidepressants have cardiovascular side effects, and this increases the risk of cardiac events in those with cardiovascular disease. Other antidepressants work directly with the nerves in the legs, helping to alleviate that limb pain. Opioids decrease endurance during exercise by slowing breathing and heart rate, so long-term use increases the risk of falling and osteoporosis and should not be used directly before exercise. Corticosteroids also help manage inflammation as NSAIDs do. And then there's also self-help methods where the amputee can check the fitting of their prosthesis. They can use heat or ice compress for inflammation. They can use massage for pain, acupuncture for pain, a TENS system, and mental imagery where they visualize using the phantom limb. And amputation affects exercise by decreasing strength, so with so much muscle mass gone, which also leads to having an imbalance, there's the other leg is overcompensating for the loss of a major limb. And then this also changes the person's gait, the way that they walk. Can be a lot more difficult depending on the type of amputation, so people might not be able to walk, they might be bound to a wheelchair. It also increases the risk of arthritis and low back pain, which could hinder the want to exercise. Imbalance can greatly put an amputee at risk while they're exercising for injury. And then, again, depending on the type of amputation, there might be a large limit to lower body exercises. So with so much of the limb being gone, or if both limbs are gone at any point or removed at any point, they might be severely limited to upper body exercises if they're bound to a wheelchair. And then exercises affects an amputee by strengthening their residual limb, increases their cardiovascular fitness, and increases their muscle mass. That all improves their balance for locomotion. So while this improves their balance for walking, it also improves their balance for actually physically being able to exercise and their activities of daily living. So in general, lower leg amputees can follow the same exercise programs as the rest of the population, and this is highly dependent on their amputation classification. So there's always room for accommodations when following an exercise program, but things such as a bilateral transfemoral is limited to upper body musculature, so having a transfemoral amputation across both femurs leaves you bound to a wheelchair most of the time, and there's not many exercises that an amputee can do with very little limb, lower leg muscle mass. And then anything below the femur, transtibial has similar responses. So below the knee, at the foot, at the knee, mid-thigh, all have similar responses, especially if it's just left to one leg that's been amputated at any point. So there are complications with amputations, usually following surgery. There's the increase of cardiac events, there's the risk of deep vein thrombosis, there's sometimes slow wound healing or the increase of infection, there's sometimes pneumonia, and then there's almost always stump and phantom limb pain, and there's a risk of muscular contracture if an amputee is not doing their exercises or their stretches or massaging the area. And then in a few cases it involves further surgery. So sometimes when there's a constant pain within the residual limb, surgeons will remove a cluster of nerves to alleviate that pain. So for my case study, I chose a 55-year-old male who is a type 2 diabetic with a family history of diabetes. He's had a transtibial amputation, and his BMI is 29, which puts him at overweight, borderline obese. He's physically inactive, and his blood pressure at 130/82 is hypertension stage 1. His goals are just to increase balance and strength so he can begin moving around independently and walk for longer durations with his family. He wants to be able to move around his house and do things freely and not depend on everyone around him. And considerations just as that he takes aspirin daily for his stump pain, and that's just considered an NSAID. So, his exercise prescription for flexibility, I would choose the groin flexibility test because it assesses adductor flexion, which is often a problem for amputees, and I want to see if that's going to be a weakness for him specifically, and if that needs to be worked on. So, for frequency, I chose 5 days per week, and intensity should just be slight tension, feel a slight stretch, not quite uncomfortable. Time should be to hold each stretch for 30 to 60 seconds, and type should just be static stretching. Volume, he should do 3 to 5 stretches at a time, and progressively increase time that he holds each stretch. For his exercise prescription for aerobic, I chose a bike test because it's seated and might be easier for an older adult that also has limited balance. Frequency should be 3 to 4 days per week. Intensity, I chose 50 to 60% of his heart rate reserve or 5 to 6% of his RPE. Time should be 20 to 60 minutes. Type, I just chose things such as swimming, cycling, walking, things that he can do easily. And with swimming specifically, it might help alleviate some pressure put on his limb. For volume, he should have a minimum of 2,000 steps per day. And so that progression would just be to increase his steps per day, or increase his time, which would also increase his steps per day. In the exercise prescription for resistance, I chose the sit-to-stand test to establish a baseline measure to monitor change over time. Frequency should be 2 to 3 days per week, with intensity being 40 to 50% of his 1 rep max. There's no specific time. This will probably take 30 minutes or more. Types just include a variety of exercises that use large muscle groups, such as stair climbing, single leg press, bird dogs, hip adductions, hip extensions, different types of weight bearing exercises. And volume should be 2 sets of 10 reps. And for the progression, we would gradually increase his intensity to 60 to 80% of his 1 rep max. And for neuromotor, which is just combining flexibility, agility, and balance, I chose the Berg balance test because it's the most appropriate for older adults. For frequency, I chose 2 to 3 days per week, with the intensity being 45 RPE. Time is unspecific. Type is to challenge any variety of exercises that challenge his balance, his sensory input, which will also challenge balance, and his postural muscle groups. So volume should be 2 to 3 sets with 8 to 10 reps, and progression is to gradually increase the challenge to balance. So that includes challenging sensory input, so closing his eyes one time while he's doing a tandem balance, crossing his arms so he doesn't put his hands out. So exercise accommodations vary depending on the amputation classification and the individual's needs. So someone with more amputation might need more accommodations. So these include wheelchairs, manual handling equipment, which includes transfer board, transfer sheet, stretcher, standing hoist, and a transfer belt. And then there's also the option of an early walking aid, which is a temporary socket made out of an inflatable bag, which is supported with a metal frame and a prosthetic or a rocker foot for them to walk on, a prosthesis if they're fit for it, and walking aids, which includes crutches, walkers, quad and regular canes. And then they can also opt to do weighted machines or use resistance bands to help alleviate using too much body weight while trying to do the exercises. Also having to depend on their balance, that might not be great. And then I suggest that they have a gym partner or supervision, especially in the early phases of their exercises. So my take-home message is that with proper guidance, lower limb amputation can be managed with exercise. And it's best for amputees to get back to their activities of daily living with accommodations if needed. And with diabetes being the main cause of vascular disease amputation, exercise is key for them. It will help improve their overall fitness, improve their blood glucose values, help control blood pressure, and improve their body composition so they can lose weight and better manage their health. And so this is my list of citations.